Good evening. Start. I'll start. Good evening, friends, and a very warm welcome to all of you on the resumption of the live webcast of these Thursday clinics. As you all know, these Thursday clinics have been going on since the year 2000 and at Sion Hospital since the year 2007. So we are extremely thankful to Lokmanya Tilak Municipal Medical College, Sion, for allowing us to conduct these clinics over so many years. And we are specially thankful to the current head of the department, Dr. Radha Ghildial Madam, for going out of her way and allowing the resumption of these clinics, facilitating the resumption of these clinics after the break during the COVID period. So we are very happy to restart the live webcast thanks to an academic initiative from Alpha Max division of Alchem, and we thank Alchem for that. I think this clinics can be viewed not only on this www.clinicalpediatrics.co.in, but it can also be viewed on the DIAP platform, where all other PG activities that have been started this year are being screened. So therefore we thank DIAP and Central IAP also for including this as part of the all-round PG activities. A slight change in the format of these clinics that we have thought is that we used to do 2 cases per clinic in the past. Now we will have one long case, and we will try and do a short presentation by one of the faculty on a topic which may be useful to students in both theory and in the practicals, and then have a discussion on that topic. So that this format we will follow from the next time or today. Let's see, our second case for today is a little unstable. So if we can bring the child, we may do the second case, otherwise we may do this format. So I think the ground rules for this webcast remain the same. All our online viewers, if you wish to answer any questions asked here, please type in the chat box. We have one faculty managing the chat box, and we will relay your answers here in the hall. Similarly, if you have any questions or any doubts to ask, please type in the chat box, and one of our faculty will look at those questions and the relevant questions will be discussed here. Those who are here live in this hall, please see to it that you speak only in the mic. Please ask for the mic and speak only in the mic, because only then all the online viewers will be able to hear what is being said. So please raise your hand and ask for the mic, and that's the way we will conduct these clinics. Okay. So thank you very much once again all our online viewers for joining. Please spread the word to as many postgraduates as possible that these Thursday clinics from LTMMC Sion have once again are being webcast on clinical pediatrics as well as on DIAP. Thank you. We start with the first case for today, which will be presented by Dr. Manisha.
A very good evening to my respected teachers, my friends and my seniors. I'm Dr. Manisha, and I'm going to present a case presentation today. So my patient, she is a 9-year-old female child, first by birth order, born out of 3rd degree consanguineous marriage, Sheikh by community, Muslim by religion, hailing from Bihar, and the informant is mother and reliable, and she brought the child with complaints of easy fatigability for last 15 days. This child, 1 year ago, developed abdominal pain for which she was taken to a local hospital in Darbhanga, Bihar, where she is hailing from, which was on and off in nature. It was more so in the left upper abdomen, which was non-radiating, not associated with food intake. She was given some symptomatic treatment for that. The mother later noticed a lump on left upper abdomen and paleness which was gradually progressing. Hence, she was taken to a local doctor where she was again admitted for 5 days. She was investigated and told to have a blood disorder which will require frequent blood transfusions. She was transfused 2 units of blood and was discharged on some medications which she was advised to take once daily. Her parents were also screened for some tests related to the disease of her daughter. Now this history, the mother on further inquiry gives history of frequent transfusions since past 1 year. She was transfused 1 unit of blood every month for the initial 5 months. After those 5 months, she had an episode of fever during which her transfusion requirement increased to every 15 to 20 days. This continued for 2 to 3 months, and again it came to every monthly transfusion for the last, and this is being, every monthly transfusion is going on for the last 4 to 5 months. Her mother says that prior to transfusion, there's paleness, the paleness of skin is increased, and there's history of decreased activity, dullness, and poor appetite, which is usually resolved on transfusion. There is no history of edema, oliguria, anuria, or any breathlessness. There's no history of any bleeding tendencies or bleeding from gums. There's no history of fever or recurrent infections. No history of bone pain, weight loss, and any swelling noticed over the body by her mother. No history of jaundice or any drug intake. No family history of any blood transfusion, gallstones, or any operations like splenectomy. No history of pain in abdomen, chest, legs, or convulsion. No history of any fever with rash, joint pain, or hematuria. There is no significant past history except for multiple admissions she required for blood transfusion. Her mother was registered at 3rd month of gestation. However, she did not take any supplements for the same during her course of pregnancy. She received TT injections, and no antenatal scans were done. There is no history of fever with rash. She was a full-term delivery, normal vaginal delivery, with a birth weight of 3.5 kgs. She cried immediately after birth, and her birth vaccines were given. There is no history of an ICU stay, or there is no history of any neonatal jaundice. She was immunized till 2 years of age as per National Immunization Schedule. She has achieved all age-appropriate milestones. Her dietary history by a 24-hour recall method, the child consumes mixed diet, 3 to 4 meals a day. However, it is deficient both in calories and proteins. There is no significant family history except for that there is 3rd-degree consanguineous marriage. As per socioeconomic history, she lives in a rented room in Bombay and with a separate toilet and bathroom, and drinks water from tap without boiling. Father is the head of the family. He is uneducated and he works in a shop and earns around 10 to 12,000 per month.
So this child came at 8 years of age with some non-specific left upper abdominal pain, and then the mother noticed a lump in the abdomen, right? And the doctor noticed paleness. So at this stage, what would be your thoughts? What could this lump in the abdomen be which the mother noticed? And when the doctor said that your child is pale, how will you add the two things together in an 8-year-old child for the first time? Any thoughts? What could a left-sided lump be?
Left-sided lump would be a spleen, and because of the paleness, splenomegaly can cause can predispose to hemolysis. Increased RBC destruction could cause the splenomegaly.
So one thought is that this could be a spleen, and if the child is pale, whether this is some kind of a hemolytic anemia. That's one thought. Any other thoughts? Can it be any other lump? Can it be a tumor? Can it be a tumor who's and then also pale? Any thoughts on that?
It could be a renal cell carcinoma causing aplastic anemia.
Okay, so it could be some other lump like a kidney lump. Now take this further. Suppose there is a renal swelling. Will the parents come to us for a lump, or we will detect a palpable kidney? Think, take it further. Good suggestion.
Sir, parents won't come with an obvious lump. It is when we will on examination might figure out, but the parents won't come, being kidney as a retroperitoneal. So
excellent. So kidney is a retroperitoneal. So that's the small difference. But good thinking. You are thinking of other organs getting involved. What else? Anything else?
for a tumor with no history of suggestive of reduced appetite or any obvious weight loss, coming at 8th year looks less likely.
Good, again. So you would start thinking that can it be a tumor, can it be a growth? But then you would think that why should it remain silent and come for the first time as a tumor with no antecedent complaints, etc. So again that puts it less on your list, right? You want to say anything?
Sir, it could be tropical splenomegaly which is causing increased hemolysis.
So now you are discussing that spleen and pallor for sure. Other differentials of spleen and pallor. So one was hemolytic anemia. We'll discuss which.
Why are you so sure that it's spleen only? You have a pain in the left hypochondrium. Okay. So take care of pain and the swelling noticed. So could it be some tumor coming from the left epigastrium, like from stomach, for example, or from the tail of the pancreas, for example? And it grew suddenly, that's why there was pain, and it came to notice. Okay, you have a pain, and a splenomegaly doesn't cause pain normally, right? So to me, the pain and the left hypochondrium swelling is the stomach or a tail of the pancreas. It is coming up slowly, but something must have happened to that tumor. For example, it must have bled. Okay, if there's a vascular, highly vascular tumor, it could have bled, caused pain, and that brought the child. And because it bled, the child was pale.
In that case, the child would be unstable.
Very good. Child would be sick. So points to make out, as you start taking a history, you start thinking, and the negative history should come out of those thinking. You could have said, no history of sickness. Okay, now that would have ruled out all that I was talking about. Then why was the pain there? So again, like an undergraduate, tell me how severe was the pain, how long duration was the pain. Okay, all that. Any organ which has a capsule, it grows, it gives a discomfort and is called as pain. But you could have said pain was mild and okay, so we pass through that. How will you ask all these questions if you start thinking what it could be? Okay, negative history should come from that. So now I am convinced it's spleen and pallor. Okay, acute pallor or chronic pallor?
One of the causes of abdominal mass is abdominal wall tumor. And it's in the abdomen, but you may feel it like that. Parents will notice it very clearly. And if it is something which can give rise to some pain. So a common cause of abdominal tumor is abdominal wall tumor.
Good. Earlier when we used to see polio or any neurological localized muscle paralysis, it would come up, prop up, it being extra abdominal and come as a lump. Okay, so all these are important. But again and again we have been talking, every clinic, the story should start how well the child was. Okay, we haven't heard that. Has this child been malnourished? Has this child been reasonably nourished but not growing? So we must ask all those details. That will tell us that this is a chronic problem which came to light only recently. Otherwise, we will say this is an acute problem. So my question was, is anemia acute or chronic? Then we will guess whether this has a chronic problem or it came up acutely.
So how do you judge from this history what questions you want to ask to decide whether the anemia is acute or chronic?
With the history, there is history of frequent blood transfusions.
No, we are not taking that. We are just now discussing when this child presented at 8 years. The frequent blood transfusion is after that. So we are thinking at 8 years what it could be.
So how, the growth of the child?
First.
Pallor will present with what? Acute pallor will present with what?
Breathlessness.
Or some other.
So acute anemia, if somebody's hemoglobin crashes from 13 or 14 to 7, what will happen? How will the child present?
Again, the blood pressure will drop, and the child will present in shock.
So sick child and in shock. So this child's history doesn't suggest that. So it's probably chronic anemia, right? Chronic anemia with that splenomegaly.
Is it chronic severe or chronic moderate? Notice so must be moderate, not mild. Can you guess whether it's chronic severe?
Depending on the age of presentation, like if it would have been severe, it would have been presented earlier. Coming on 8 years, apparently looks like a moderate.
No, the reason for moderate and severe can be different. Who noticed it? Mother or doctor? So if doctor noticed, then mother didn't notice. If it was severe, mother would have noticed. She would have come with pallor as a chief complaint, right?
The point I wanted to make was that even if the anemia is chronic but severe, it may not come in cardiac failure. Severe anemia comes in cardiac failure. But when it is chronic, slowly progressive, the nature takes a balance reasonably to the last minute, and cardiac failure may not occur. So the difference between moderate and severe is not so easy at that point of time.
Also, they may come rather for exercise intolerance or easy fatigability rather than going in frank failure. He walks a little bit, now doesn't play, gets tired very easily. So the anemia will manifest, but in a different way.
So, sir's question was that at that 8 years, how was the child before that? What is your history? So 6 years, 7 years, 5 years, how was the child?
So as per the historian, when I asked certain questions, the mother said the child was growing well amongst the peers as compared to her friends. She was growing well. She had no prior history of any admission or any illness. It was a very sudden presentation that the mother noticed. She had increased paleness of skin and then the pain in abdomen.
And active, playful, everything was normal,
Yeah,
as playful
she
as
used to
other
go to
children.
school. She was very good in, as per the mother, she was very good in scholastic performances.
So few remarks from the chat, and we are having some activity there. I was busy sorting it out. So Dr. Pratha and Dr. Saha said it could be a splenomegaly or a left-sided lump that we are discussing. And Dr. Anjali said it could be a Bezor, which could also present as a lump, sometimes on the left side. And acute anemia can come with decompensation, but chronic usually comes with growth failure. These are some of the comments.
Okay, so now let us start thinking what kind of a hemolytic anemia can present at 8 years. So what are your thoughts?
Why hemolytic anemia? It could be storage. You have a splenomegaly, storage. That same material is getting stored in the bone marrow. And now you also have anemia. The story of tiredness has come recently. Okay, so possibly you have a chronic problem which started about a year ago at 8 years of age. Storage. Started with a spleen, Gaucher's, then went on to involve bone marrow, and now presenting as severe anemia. So first tell me why not that? So both bone marrow infiltration and hemolysis both can cause splenomegaly. Will you dissect that and say why this is only splenomegaly due to hemolytic anemia? Some thought. Come on, give a thought, doesn't matter. Okay.
Sir, bone marrow infiltration more likely will be hepatomegaly with or without splenomegaly, whereas hemolytic is predominant splenomegaly and later on can have hepatomegaly.
Any other thoughts? What about the time frame of events?
Sir, age of presentation will be much younger in storage diseases.
Okay. Any other thoughts?
Infiltrate or storage disorders, they are usually sick, and there will be associated symptoms in case of leukemia like bone pains, and child is usually sick compared to a chronic hemolytic anemia, child is well.
I think for storage 1 year is a short duration. For typical storage like a Gaucher's would start with little splenomegaly, missed for a while, looked at maybe malaria, some fever, and then the spleen starts enlarging, and over some more time it starts enlarging, and by that time you start dying. Well, there are spectrum. For example, an infantile Gaucher's would present with a neurological manifestation, etc. We are not looking at that. We are looking at a typical splenomegaly gradually increasing. This duration looks shorter to me for that kind of a storage. Then the growth failure should have been much more prominent in a storage disorder. Of course, in a chronic hemolytic anemia also, but if it started only 1 year ago, then that storage is less likely. It should have started much earlier, though not noticed, right?
Okay, so if we are thinking of hemolytic, any thoughts on which ones it could be? Come on, let's run through all of them and think whether it's possible, not possible. Could it be sickle?
Yes, because there was pain also. Pain in the left hypochondria.
In sickle, then she would have other complications also, bone pain or any acute crisis. And the sickle crisis, that pain in abdomen would be more severe and not so chronic.
Okay. What else?
The number of transfusions which the child received goes.
No, now we have not yet started giving transfusions. It's at 8 years we are discussing. Once they get transfusions, it becomes easy.
There is no jaundice, so I think it could be a thalassemia major. Other hemolytic anemias usually should have jaundice.
So does sickle have jaundice? No? Why not?
Haptoglobin and hemopexin.
Hold close, hold close.
Haptoglobin and hemopexin may clear off the unconjugated bilirubin due to hemolysis, and it will be intermittent, sir. It won't be continuous.
Very good. So the main reason is that the hemolysis in sickle is intermittent. Can sickle ever have jaundice? When does it have jaundice?
In crisis phase only, sir.
Okay, so one is hyperhemolytic crisis. Any other?
Hypermetabolic states like fever and all, if child is having, then.
Okay, any other? What is sickle hepatopathy? So in case the liver takes the brunt of the sickling process, then at that time hepatic functions go down and you could end up with a jaundice, right? Okay.
Does sickle have a large spleen? Does sickle have a large spleen?
Yes or no? It's very simple. Toss of a coin.
They can have a large spleen till 4 to 5 years, and then autosplenectomy will cause a regression.
Excellent. So there are a few comments from the chat, so I'll keep getting up and intermittently talking about it. They have said that it could be unlikely to be storage because till now we haven't thought of liver enlargement along with a left-sided enlargement, and it could be a hereditary spherocytosis or sickle thal combination, or sickle can present more with crisis rather than with pallor, and autoimmune hemolytic anemia may be considered. There are some remarks from other faculty like Dr. Palniraman and Dr. Vijay Yevle, etc., which I'm not going to mention here right now.
Okay. We discussed sickle. What about, so they have suggested hereditary spherocytosis and sickle thal. So likely, unlikely, what do you think? Any discussion you want on that?
What history do you want in a spherocytosis? See, all chronic hemolytic anemias have a stunted growth, which they have said possibly not in this child. Any specific history that would put you to possible spherocytosis? Autosomal dominant, right? What history would you ask?
So how will you ask that family history?
History of splenectomy in the family.
Okay, so splenectomy in any parent or?
Gallstones.
Okay, or?
Transfusions.
So short stature in the parents, or short stature means growth
Short
failure.
stature. He may not know he has spherocytosis, but he is short, right?
Dr. Mohita is mentioning that, like what Dr. Mamta Manglani also has been staying in this clinic, is certain patients with a certain phenotype in sickle may not always have autosplenectomy, though that is usually seen in certain type of phenotypes. You may not have a autosplenectomy.
Okay, so can this be thal major?
Age of presentation, sir. It will be after 6 months. Usually it presents early in the life, sir. Thal major will present much earlier, sir.
So can it, means is it that this cannot be thal at all?
It can be thal intermediate, sir.
Okay. So normally why do thal intermedia, what this term thal intermedia, which now we say as beta 0 and beta plus. So why do they have reduced requirements, or why do they present late?
It is a heterozygous state, sir. So it will take, they have HbA levels higher, sir.
Okay, and?
So late presentation.
And? Sometimes a lot of extramedullary hematopoiesis sustains them for a certain length of time, right? So sometimes you see these children with florid signs of extramedullary hematopoiesis. Okay?
Can it be non-hematological at all? The child has happened to pale, he has extrahepatic portal hypertension and a big spleen. He has not bled so far, or maybe he has bled earlier, we don't know. No hematological cause. Can it give rise to pallor? Normally no, unless there is a recent history of bleeding. Otherwise there should be no pallor. So if there is pallor and splenomegaly, then these things are less likely, though they may cross your mind.
So Dr. Nitika is asking, can it be a non-transfusion dependent thalassemia with some acute illness occurring at 8 years? And if you say yes, it can be, then you have to tell us what pointers would you want on history to confirm or negate the same?
Anybody to take that?
Understood the question, right?
Anybody?
Which acute illness would suddenly drop hemoglobin? So here's a thalassemia intermediate, not requiring much transfusions, and now he gets an acute illness where it drops hemoglobin further and comes to you. Here's a spleen, that is thalassemia intermediate, not requiring transfusion, but now he comes to you with severe pallor and now needs transfusion. So, which illness can crash hemoglobin in a normal child as well as in a thalassemia intermediate child?
Malaria. Malaria.
Malaria, all right.
Anything else?
Which infection typically can crash? Malaria, yes.
Parvo.
Okay, malaria, yes. But malaria, depending on what is the amount of hemolysis occurring, okay. And it's rare to have a crash of malaria, right? Yes.
Just a comment for all the students, colleagues and teachers on the chat. We are monitoring your chat very regularly, but your enthusiasm is something I cannot cope up with, so I won't be repeating all the messages and comments. Whatever is out of what has not been discussed here or what is going to be discussed, we will try to cover it.
So, sir,
so
you
why
can...
not acquired hemolytic anemia? One thought came from the message. Okay, at 8 years, started
Autoimmune hemolytic anemia. Any thoughts on that? Sir, you sum up now.
This is obviously.
We must start thinking epidemiology. If a child comes from Bihar, you must think of Kala Azar.
Fine. Okay. So the question is, many of the acute autoimmune hemolytic anemias, acute, are of a short duration, come with mild jaundice, pallor. Spleen is rarely so big because it's an acute onset problem. Could there be a chronic autoimmune or immune-mediated hemolytic anemia? Okay, which is rare. What about paroxysmal nocturnal hemoglobinuria? One type of a hemolytic, okay. Is that a possibility? What is hemoglobinuria? Where is the hemolysis occurring?
Intravascular.
Yeah, this is extravascular, no? So no question. Okay.
Dr. Palniraman is asking, can it be a CML, chronic myeloid leukemia?
Yeah.
Left-sided lump you got, so spleen, chronic disease. So argue for or against it.
Any thoughts, any points for or against?
I'll give you a clue. Does acute lymphatic leukemia presents as pallor? Severe pallor? Why not? It's leukemia, no?
They'll present with other symptoms like night sweats and weight loss, lymphadenopathy, fever.
Putting the same question in another way, out of the 3 series, which one shows first and why? Common. I mean, it's not a rule, but commonly.
So point is, if it's a lymphatic series going, then there is no reason why suddenly the anemia is severe. Same is story with a chronic myeloid leukemia. Present with a large spleen, but a moderate anemia. Anemia is often not a presenting feature at all. Okay. So wherever, for anemia to come up, RBC should be involved. Okay. And therefore, that is very unlikely. So coming back now, so one is thalassemia minor, thalassemia intermediate, with some acute onset, but there is no acute onset story. So that puts us off. So now what it could be? So could a thalassemia intermediate to start with, not noticeable, mild to moderate anemia, okay, splenomegaly mild, not noticed. But now for some reason there is further destruction of RBCs. Can that occur? Let me give you another clue. Typical thalassemia measure, who starts transfusion every 4 weeks. Thereafter he needs every 2 weeks. Why? Hemolysis is increased. HbF is increased. What has happened?
So, could it be?
Yes.
So, since the child is frequently transfused, could it be alloimmunization in the child?
Okay, so one thought is alloimmunization. More common or different possibility of increased transfusion requirements in such situations?
Which is almost a rule.
Hypersplenism.
Very good. Hypersplenism.
Hypersplenism. Can this be an initial thalassemia intermediate, okay, getting into hypersplenism? So the question related is hypersplenism related to size of spleen or just the function of the spleen?
Splenic function.
So not the size of the spleen. So it may not relate to the size of the spleen. So keep all that in mind. See, so the issue is either have we missed the initial period of faulting growth, whatever, but the story doesn't say that. So it's not very chronic from early age. Then was it really only last 1 year? Then it must not have been a typical beta 0. It must be beta plus. And if it's beta plus, why did it get worse now? So the question is, so this is the way we would have analyzed, right?
And now we add the subsequent history that this child has received transfusions almost every month. So now what do you think it is? After adding all that history, what do you think? So many of our differentials which we discussed, hereditary spherocytosis, etc., are now ruled out. No, with every month transfusion, those are ruled out. So what are you left with now?
So hemoglobinopathies might not be thalassemia major, but non-transfusion dependent thalassemia or any thalassemia syndromic.
Okay, so mixed hemoglobinopathy or whatever.
Yeah, heteros.
And then why suddenly so many transfusions? So that the reasons remain the same, hypersplenism, etc., right? Anything to add, sir?
Just wanted to ask you, since you are discussing non-transfusion dependent thalassemia as one of the differentials here, what pointers would you look for on history? You get my question? If the child has thalassemia intermedia, on history, how can you make out other than transfusions? Suppose this child has not been transfused. Can you make out on history anything? Any pointers?
There was history of increased fatigability.
Very good.
And tiredness and drowsiness, poor appetite before the
height may be affected.
Yes,
and would they have more prominent features of thalassemia or less prominent features of a thalassemia compared to a well-managed thal measure?
More features, as discussed earlier, that the hemolytic phases would be more prominent.
And even abdominal distension due to hepatosplenomegaly maybe.
And many thalassemia major or thalassemia intermedia patients have a history that when mother went for her pregnancy check or a delivery, the doctor always said your hemoglobin always remains at 10, and in spite of iron also that it did not increase. This is very common to find out, and that tells you that no, her hemoglobin is only 10, it doesn't increase even after iron supplements, so that must be a thalassemia minor as well in her. And this is very common when the mothers come and say, but they said it's all right. No, they could have been investigated.
So now tell us your provisional diagnosis after history.
So a 9-year-old female child who is born out of third degree consanguineous marriage, was birth and developmentally normal and immunized till 2 years of age, who came to us with complaints of easy fatigability in a known case of transfusion dependent hematological disorder. So it's most probably, sir, a case of hemoglobinopathies or, sir, autoimmune chronic autoimmune hemolytic anemia was presented in a.
So can you give us reasons why you are considering autoimmune as a possibility?
So more so because of the age of presentation. So
Age of presentation. Okay, fine. Tell us the examination findings.
So before that, as usual we do it, what must be the weight and height of this child? 9-year-old. Story, a year ago the child was all right. And the story of only of anemia. Okay. What must be the weight and height? And justify that. See, nobody is going to ask you not to wear the child. But this is just to keep on thinking how much we can know only by thinking and analyzing the history. So, yeah.
Sir, around 24-25 kgs, like a well-grown child. So if we take 2.53 kgs at birth, he must have be around 9 kgs at the end of 1 year, then every 2 kgs per year. So 16 plus 9, roughly 25, 26.
Height?
Uh, 100 and...
What is the normal height at 8-9 years? And do you expect it to be affected? So 4 years is how much?
Roughly 100.
And then?
Then every
5 to 6 centimeters every year.
So 5 more years. So 30.
130.
But I think given allowance, okay, the point is we know that this child must be suffering for a long time. Though not suffering necessarily by calorie, protein, etc., growth, but somewhere there must have been, because our impression is something that started silently and then worsened over the last 1 year. And therefore, give an allowance for that and then bring it down. Of course, it will depend on the genetic stature, the nutrition, etc., all that. So let's see now.
So in examination, the child pale and she's lying comfortably on the bed with IV in situ in right hand. She was afebrile, active and conscious and oriented to time, place and person. She was cheerful. Her pulse rate was 108 per minute, regular, normal in volume and no radioradial and radiofemoral delay. Her respiratory rate was 24 per minute, was regular and thoracoabdominal in nature. Peripheral pulses and central pulses were well filled. Her SpO2 was maintained on room air and BP was maintained between 58 to 98 centile. Her weight was 18.4 kilos, expected against a weight of around 31 kilos, which makes her less than -3 standard deviation. Her height measured was 125.1 centimeter against expected against 131 centimeters, and that makes her fall under -2 to -1 standard deviation, and with a BMI of 11.79 meters square, expected against a BMI of 16, which again makes her to less than -3 standard deviation. So as per anthropometry, she is severely thin child. So the patient is.
चप्पल खोलेंगे सर 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 Can
somebody come forward? Somebody come forward and start first talking on inspection from a distance.
Utkarsh. One more person, come.
She appears to be she appears to be an alert she's quite interactive, and the growth there's no obvious frontal bossing which I can see, and
Yes, sir. From head to toe examination, I would comment on hair. Hair are lusterless and not sparse. And forehead is normal. In eyes, there is mild icterus. Mild icterus can be seen. Flat nasal bridge is there, and prominence of malar eminence, so hemolytic facies. Ears appears to be normal. In neck, there is no obvious swelling.
What else in the context of a hemolytic anemia that you are thinking of? What else do you want to look at? Malar prominence?
Yes.
Yeah.
Yes.
Abdominal distension, you think, is there?
Doesn't look like.
No, doesn't look like. Okay.
Pallor, mucosal.
When there is pallor, few things must come.
Yes, sir.
Pallor, pigmentation, purpura.
Okay, sir.
Is there anything?
No, sir.
She has put some artificial pigment, but otherwise nothing.
Clubbing.
Head on this side? You can go up. Quickly examine the abdomen. I'll hold the mic for you. Examine the abdomen.
Sir, the abdomen doesn't look to be distended. The umbilicus looks everted. There is no obvious flank fullness, and the abdomen seems to be moving in all directions, and there is no obvious any dilated veins over abdominal wall.
So actually, I mean, there's no frank fullness, that is right, but you would have said the abdomen looks a little full, and especially the left side looks a little more fuller than the right side, right?
Upper abdomen is of course more distended and lower. There is definitely upper abdominal distension, right side, left more than right.
I think in an examination, always look at stay at the foot end, stay at the same level, and then look at the abdomen. Just as a routine. If there is something very minimally abnormal, you will miss it when you are overlooking it. So it's always nice to be at the foot end and at the same level, and then look at it, right?
You
Just
will
take care
overlook
of
when you are overlooking it.
Palpation.
Do you think the umbilicus is a little lower?
It is somewhat shifted.
So
now.
what does that mean?
This predominant upper abdominal.
So some upper abdominal mass, but definitely the umbilicus looks to be a little downwards as compared to the midline, right? In an exam, always warm your palms. And if it's an older child, always tell her, I'm just going to examine, it won't be painful. Now, these are all routine things which are expected out of a doctor, okay, which we often ignore and we are often not taught. But always do that, okay. And you comment whether he's doing correctly or not. You watch carefully and see whether he's doing it right or not.
दूसरे का तो था ना अभी कुछ दिख रहा है so the superficial and deep palpation there is no obvious the child doesn't complain like no obvious findings in superficial and deep palpation लंबा सांस लो सांस होल्ड रखो
So good method of palpation here is, of course, apart from what Sir said, is never lift patient's clothes on your own. However small is the kid, whether it's a girl or a boy, just ask mother to do it or ask the patient to do himself or herself. Remember, today every child is taught about good touch, bad touch. So if we start flouting those rules and examine the patient in that way, they will get very confused about how we are examining them. Secondly, when you are doing the abdominal examination, try to keep your hand, the wrist should not be in this position. So don't stand in this position and do it. Try to drop your elbow so that your hand is kept like this and then you are palpating. Also, when you palpate, just maintain the pressure and allow the patient to take a deep breath and allow the liver or the spleen or the lump to come and touch your fingertips, rather than you to go searching for it.
I think point Tushar made was deep palpation is different for different purpose than superficial palpation. Superficial palpation, let the liver spleen touch you. Deep palpation, if there is anything deeper that you might miss. So, but first, only superficial palpation, right?
So liver appears to be like 2 to 3 centimeter below right costal margin, and लंबा सांस लंबा सांस लो I could not much feel the spleen. Like
when you were palpating, we could see the spleen rather than seeing. So, I'll take this to shield my warm temperature. Now you are going like this. If you go here, the spleen is very much there. So when you were pressing like that, we could see the bulge coming out this way, knowing thereby that you are a little too medial to the spleen. Okay, so when you don't get it here, you come here. See, it's here. The lower end of ribs is so much. Okay, and we could see that you were doing this, and I could see the bulge and even an edge here of the anterior area of the spleen. Okay, so if you don't get it here, come down, and here you don't have to do, there's no need for deep palpation. Here also. लंबी सांस ले बेटी. Shabash. फिर से. Shabash. Very good. Then all along. फिर से. He'll see. May not be relevant here, but upper bord is not to be missed by percussion. So big liver and a very big spleen.
So again, I think Tushar already emphasized the position of the hand. You flex at the MP joint and you don't dig like this when you are palpating. When you're going for the spleen, go from the iliac fossa towards the left costal margin like this. So if you go like this and all, then you might miss it, right? Okay. Quickly tell us the positive findings.
Rajesh, just one more point here. I don't know how many of you are following Hutchison. Then the last few editions of Hutchison's mentioning the liver to be palpated in with the tip of the finger and not edge of the finger. All of us traditionally have been doing that, and many of the pediatric books still maintain that. I am not an authority to say which of the two is correct, but just know that both are possible, and you know that you get the liver size and texture and everything else same as the examiner would get. Whenever you finish your examination, please, yeah.
I just thought it was more of an adenoid facies, and the maxilla is so narrow, that's why there is crowding of the teeth. And if you see even the open mouth posture with hypotonia, so we need to see into the throat whether there is any adenotonsillar hypertrophy. Though she has mentioned everything to be normal. There's no bossing.
Okay, just quickly run through your findings. Anything different from what we have discussed?
Yeah, there's
just
a chronic
tell the
liver
positive
disease.
findings.
It's a chronic liver disease. Liver span is increased, liver is large, spleen is there. That's what he was trying to say, that this could be a chronic liver disease, isn't it? We don't expect large liver, right?
Child should be stunted by now. So if it is a chronic liver disease, height is between -1 and -2 standard deviation, only weight is affected.
So how do you rule out it's not a liver disease?
Child should have chronically unwell. Previously, the child should have some symptoms at least before the presentation of before 8 years.
Child should not have history of frequent transfusions, frequent blood transfusions.
So only on examination, what would you think are the points? So you have to talk of presence or absence of hepatocyte dysfunction. So how do you get hepatocyte dysfunction? Clinical signs? Jaundice, then edema, then growth failure, so height being affected, right? And finally spleen more than the liver, no ascites. So you add all that and say it's not a chronic liver disease. Besides liver and spleen, any other positive findings? No.
No, sir.
Okay. So what's your final diagnosis?
It's a 9-year-old female child born out of consanguinity and birth and developmentally normal with pallor, mild icterus and hemolytic feces with splenohepatomegaly in a case of with transfusion dependency, and who came to us not in failure, is a case of hemolytic anemia without any disease related complications. So she is most likely a case of hemoglobinopathy or autoimmune hemolytic anemia.
Can you run through the investigations?
So no investigations.
Okay, not yet investigated.
Yeah. So actually she was previously investigated. Those papers we got today, but we are again running through the investigations, sir.
Okay. How will you investigate her?
So first we'll do a basic investigations like complete blood counts, her liver function tests we'll like to do, and we'll see a peripheral smear and we'll see retic count for the child, and based on that, so we'll further work up.
What does the previous investigation show the electrophoretic pattern as?
So she's actually HPLC reports. We got the pictures today. Her hemoglobin F is 23.7%, A2 is 6.1%, and she is HBE beta thalassemia, with both her parents being beta thalassemia trait. And so I would like to add to this, after she came to us, so we wanted to transfuse her, since her pre-transfusion hemoglobin was 3. So there was no bloods that were being cross-matched with hers. So we sent an extended cross-matching and elimination panel, and it came out to be warm and cold autoantibody positive for the child.
Fine. How will you manage this child?
So this child will require, first I will counsel the parents regarding her disease, and then if the child requires transfusion, then we'll transfuse the child, and every time we'll monitor her growth and her complete blood counts, basically her hemoglobins and her liver function tests, and depending on that we'll let the parents know if she requires transfusion or not. And if the growth is faulty, and even if she is maintaining her hemoglobin, then would more likely like to start her on some medications.
What do you think is the significance of these warm and cold antibodies in her case?
Her prior transfusions, maybe there was something in her prior transfusions that triggered these antibodies in her body.
Okay. And that's possibly some explanation for the
frequency of her transfusion.
Increased transfusion requirements. Okay. And originally HBE beta thal. Okay.
One small, not a comment, but some suggestion that you should be able to interpret the peripheral smear and simple CBC of a thal. You may go to electrophoresis, etc., but just CBC, RBC count, then your MCV, MCSC, they may be simply asked, and we may think it's too common to be seen. And on peripheral smear water, because what is both are microcytic hypochromic, how will iron deficiency differ, how will the RBC differ?
Chalo, one of you take this up quickly, then we move to the second case for today, hopefully. So how does a CBC make you suspect that this is thalassemia?
Hemoglobin low, next. RBC count?
MCV is low in iron deficiency, where it can be usually normal in thalassemia.
No, thal also will be low, no? It's a DD of microcytic hypochromic, no?
RDW will be high in iron deficiency anemia, which usually will be normal in thalassemia.
So normal in which thalassemia? Thalassemia major or thalassemia trait? Trait. So what is the RDW in thalassemia major? It is very high. Okay. So trait is normal, iron deficiency is high, thalassemia major is very high. So how do you describe, what is the adjective described for a peripheral smear of thalassemia major? What is that word? Mamta Manglani madam's favorite.
Often uses that word.
Bizarre smear. Okay. So everything very weird is seen.
RBC abnormalities are seen there.
Okay.
Tear depth is that. And of course, what about normoblasts? Are there normoblasts or no?
There are.
Yeah.
There are in thalassemia.
Quite a few. We will never get it.
So one is, why are the normoblasts there? And second, how do they affect your CBC picture?
So they show a false positive WBC count, high WBC count.
Why?
They more or less look like a.
Why?
Give anyone to give the exact answer.
So
The new.
Nucleated.
Yeah.
That is.
Very good. So they are nucleated RBCs, and the machine counts nucleated cells as WBCs. So that's why the WBC count goes higher, right? Okay.
They will also ask you about how to calculate the corrected WBC count in that case. And therefore say 20 normoblasts per 100 or 30, then you be ready with the calculation for that.
Just probably not discuss the CBC here and gave us directly HPLC because the child has had multiple transfusions and they would not have a pre-transfusion, the first pre-transfusion report. And so it becomes very difficult or what I would say not reliable to analyze that report.
Sir, anything else on this? Yeah, Sridhar.
About the new drug for thalassemia. Something new in the market. Anybody? So, you save transfusion, you prevent iron overload, you regress the spleen. What is the drug? Now we put them on that drug. So it's first started off in Pune, and there was no ethics committee there. They got into trouble, just like sildenafil. And then there was an ethics committee which came in Gujarat, and now they have come out with a big study with very good results. But now they feel only one out of the two drugs is essential. What is it? None of you all? Hydroxyurea thalidomide combination. Thalidomide is anti-angiogenic, IL-6, caspase 8. Now just an oral medication, peanuts. It doesn't even cost much. Hydroxyurea. The only problem with thalidomide is you need to monitor for neutropenia, and there is a tendency to thrombosis. So adults, they usually give you a low dose ecosprin. So this is something which is a wonder thing that has hit the market as far as thals go. So no need for a transplant, no need for transfusion repeated, no need for bringing down the iron. Transfusion requirements come down, it's all through HbF.
So very nicely presented, Dr. Manisha. Thank you so much. We don't have any other questions on the chat, right? Okay.
Normally we have planned one case only so that we can take you right up to management, prognosis, all that. But today we had two cases, so we are running short of time, so we will stop at this point. From next time we will have... So from next time we will have one long case which will take you right from discussion up to management and all that, and then one talk. Okay? Yeah. So today we will have another case to be presented. Thank you very much.
Thank you so much, sir.
So the second case, the child is sick and could not be brought just now, but the case will be presented by Dr. Anjali and we will discuss the case. You have it on this, how will you project it?
Good evening, everyone. I'm here to present a case on altered sensorium. Shall I? Hello? Shall I start, sir? Sir, my patient is 9-year-old male child, sir, Mohammad Razik, second birth by order out of 2 live children, born of non-consanguineous marriage, Muslim by religion, a resident of Nashik, Maharashtra, brought by mother, informant being mother, sir, reliable. Complaints of headache for 12 days, 24 days before. Complaints of fever on and off episode for 12 days, 20 days before. Complaints of vomiting, lethargy, jerky movements of limb, intermittent episode 20 days before. Complaints of paroxysmal activity 4 to 5 episode 12 days before. Complaints of inability to use both upper limb and lower limb since 12 days, sir. Complaints of inability to speak since 12 days. HOPI, sir. Child was apparently alright 24 days back. Then he was started to have headache. Headache was sudden in onset, intermittent, more on bilateral temporal side with occipital involvement, dull aching in character, not associated with blurring of vision or photophobia, mostly localized only, persistent throughout day, more in early morning, does not have any aggravating factors like cough or on strain, and not having any relieving factor. Does not awaken child from the sleep. For above mentioned complaint, parent took the child to local practitioner. He advised some medication, sir, advised to take thrice a day. Symptom did not relieve despite of complete course of treatment. Child also complained of fever, which was acute in onset, intermittent on and off episode, low grade to start with, progress to high grade, not associated with rash, chills, rigor, not having any aggravating or relieving factor, no diurnal variation seen. Along with this complaint, child also had a loose stool, 4 to 5 episode, watery mucus in consistency, yellow in color, not having any foul smelling, blood in it. For this complaint, child was hospitalized at Jairam Hospital, Nashik for 4 days, sir. Symptomatic treatment was given and then child was discharged. After 3 days of being discharged from hospital, patient started to have high-grade fever spike at home, not relieved of any medication, with vomiting, which was projectile, non-bilious, containing food particle only, 4 to 5 episode, not related to food consumption, not preceded by nausea. Accompanied with above complaints, mother also noticed child had jerky movement of all limbs, subacute in onset, intermittent, lasting for 3 to 5 minutes, which persists throughout day, not having any aggravating factor, does not get a bit in sleep, with no loss of consciousness. At same night, child had first episode of paroxysmal activity, which was observed by the mother when child was sleeping, sir, in the form of tightening of all 4 limbs, uprolling of eyeball, frothing from mouth seen, with loss of consciousness but not associated with loss of bowel bladder control. For same complaint, parent took the child to Birla Hospital, Nashik, was admitted for 20 days, treatment taken in the form of injectable, blood investigation done, fluid from back was taken, neuroimaging done suggestive of some infection. We don't have any details for that. During 12 days of ward stay at night around 11 p.m., child had second episode of the paroxysmal activity started of right focal side with loss of consciousness, lasted for 1 to 2 minutes, shifted to intensive unit, injectable was given, convulsion aborted. After this incident, next morning, child woke up on his own with spontaneous eye opening was there, but mother noticed child was having inability to speak in the form of decrease in number and content of the words, progressed to complete paucity of speech. Child was not able to speak, does not recognize mother, not follows command. Mother also noted child is unable to lift his hands off the bed along with legs, unable to lift his head off pillow. Child was not able to turn side by side individually. Child is bedridden since then. For negative history, sir, history of altered sensorium is there, history of altered behavior is there, history of difficulty in speech before and after illness in the form of paucity of speech, history of paroxysmal activity, which suggests cortical involvement, history of increased motor tone noted by mother while dressing up or changing the pants, history of weakness in both upper and lower limb, history of tightening of upper and lower limbs, history of there is no history of sudden loss of tone of the muscle, no history of loss of touch, pain, temperature, no history of oscillatory movement of eyes, no history of intentional tremors, no history of frequent falling while walking before can maintain posture while standing, no history of excessive sweating, drying of the skin, no history of dizziness, no history of falling while playing. For cranial, for now there is no involvement, sir. History of for etiology, no history of head trauma, fracture.
Okay, if it's no, then just go on.
Sorry, sir.
Anything positive here?
No, sir.
Okay, let's go move ahead.
In past history also, there is nothing significant for now. Birth history not significant, sir. Immunization, immunized till 5 years only. Developmentally normal. There is no similar history in family also, sir. Sibling also normal. Developmentally normal kid before.
Okay, wait. We'll just discuss the case. Go back.
Yes.
Go back.
Okay, sir.
No. Go to the second slide. Okay. So what are your thoughts when you heard the history? Started with headache and fever. So what would be your thoughts at that time?
So starting with headache and fever, first would be meningitis.
Okay, meningitis. Why do you say so?
Then we would ask about further altered sensorium or history of any abnormal limb movements or loss, vomiting. Depending.
Okay. So no, a typical, so would you say this is acute or is it subacute or is it chronic?
So
Subacute.
Yes.
Subacute, sir. Chronic headache is more than 3 months, sir. So it is subacute onset only, like duration only. And for this age group, most commonly we should thought of like refractive errors, but that could be associated with photophobia, blurring of the vision. This kid is not having blurring of the vision or photophobia, and this is like mostly localized or probably holocranial, which is now a child is saying that mother is saying that child was having some localized headache.
Yeah.
Comment on refractory error and headache.
So the refractive errors per se are not the reason for headache.
But do they give rise to something? Is there any relation whatsoever?
There's a discomfort maybe which can be...
As long as you are reading and you take your eyes off and the headache is gone.
Yes,
So refractory error
relieving
is not
factor
a
is
cause
there.
of these kinds of
Yes,
headaches.
And also not photophobia and blurring, as you say. Blurring means the vision may not be clear, the child may not be able to see properly in school, etc.
Yes.
But not blurring in that sense, right? Okay.
I think this child started with fever and headache on the first day. Does intracranial infection starts with fever, headache on the first day? In a bigger child? There should have been fever for a day or two and then going up to intracranial symptomatology. So what do you make out with fever and headache on day 1 itself?
I see.
And we haven't heard further what has happened to headache thereafter.
For that child was having repeated visit to the OPD basis only, was given painkiller, sir. For some time he responded, after that he didn't respond at all.
So did headache go on worsening?
A worsening headache, sir. Chronic progressive headache.
So what is this fever and headache on day 1?
I see.
Day 1, if we are seeing the child on the first day, headache and fever, we should rule out sinusitis also for the child.
What sir is asking is that very typically in an intracranial infection, you will start with fever, then the infection takes 2-3 days to localize to the CNS, after which you get symptoms of raised ICP in the form of headache. So in that context, does this have a different meaning, both starting on the same day? That is the context sir is asking. Any thoughts what could have changed or what is different?
What I'm trying to say is that parents come out saying that it started with headache and fever, but we know that it is unlikely that an intracranial infection like meningitis starts with fever and headache to start with. So we need to look little more in details, and the commonest cause of fever and headache on first day is a simple viral infection. And how do you make out? When fever goes down, the headache also goes down. And fever comes up again, the headache comes up again. But for the parents, you have fever and headache. So get all these details. And again, same thing what we said in the first case, Start thinking moment the history starts coming up. Fever and headache, what it is. Now, if the headache is worsening thereafter and the fever is also continuing thereafter, then I know that is something much more sinister. But in that case, fever should have preceded some time before headache came in. So ask those details for the parents. Many times both are together, and I think that is important.
Go to the next slide. So now, what do you make of this vomiting and the jerky movements? What is your thought? Analysis?
Early signs of the raised ICT, sir. Headache,
Okay.
fever and vomiting.
Okay.
Yes, sir.
And what about the jerky movements?
Jerky movement, I have asked the mother, it could be shivering along with the fever, which is she is telling that jerky movement of the all limb, which is lasted for along with the fever only, sir. Temporal association was there, and if it is involuntary movement, it could be, it should not get abated in sleep or, since it consciousness is not impaired, so it could be shivering along with the fever only.
So actually again we need a little better history. It may not be, maybe the parents are not able to tell properly, but shivering will not come as jerky movement. Jerky movements are different. Every parent would say in shivering, they'll say it in local language that the child was shivering, right? The parents can make out shivering. So maybe we don't have the correct details of these jerky movements.
Yes,
now this paroxysmal activity happened on which day of the illness?
Fourth day of the illness.
Sorry, just one more point to correct or elaborate. Most involuntary movements abate in sleep. Okay? In a hurry she said it otherwise, so just clarifying that.
This is on day 4 of the illness.
Day 4 of the illness, child had first episode of the paroxysmal activity, sir.
Right.
For which was noticed by the mother. Child was having fever that time, and in the form of tightening of the all four limbs and uprolling. So for this,
now what do you make out of this? So you started with headache, fever, vomiting, and now a seizure on day 4 of the illness in a how old child?
9-year-old, sir.
9-year-old child. So what do you make out? Yeah, come on, anyone?
Fever, headache, vomiting is suggestive of meningitis. It could be meningitis. And now with paroxysmal event, there is involvement of the cortex as well.
Okay. So now this is again acute, subacute, chronic, as in you are thinking of bacterial or viral or tubercle or what?
For TB, sir, it should be low-grade fever spike, sir. High-grade fever spike is usually associated with the viral cause of encephalitis, sir.
Okay. But TBM, can it be associated with high-grade fever?
Yes, sir. Progressed fever.
Yeah, so there it can be high-grade fever even in TBM. So just the intensity of fever does not sort of take you away from tuberculosis,
Yes.
right?
Yes.
Can it be bacterial meningitis?
Yes, sir. Associated etiological other symptoms should be there, sir. For bacterial, like sore throat should be there. For most common bacteria which seen in this age group, sir, streptococcus. So it should be having some sore throat or some other symptom, respiratory compromission should be there, sir.
I don't think so. Those symptoms are not so common at this age. I wouldn't agree to that.
I think in an older child, acute bacterial meningitis takes time to involve encephalon. Okay, because it's only localized to meningitis. And unless the child was not treated at all or the infection was fastly spreading, it should not spread to the encephalon for some time. Unlike a small child, where the encephalon involvement comes much earlier, and therefore this looks like less likely bacterial meningitis, because on day 3, day 4, this child is throwing a seizure which looks unusually fast involving an encephalon, unless the host was abnormal or the organism was such that it was spreading very fast Yes, that may be possible. But let's call it now meningoencephalitis. Okay, it started as meningitis and is becoming encephalitis. So let's call it a meningoencephalitis, and typically a bacterial meningitis at an older age is less of encephalitis. It stays as meningitis for quite some time. If viral meningitis does not almost involve encephalitis also, and it quickly gets better by itself. So this is unusual. A typical viral encephalitis does not have meningitis. Typical viral meningitis does not have encephalitis. And bacterial meningitis doesn't have encephalitis so early. So you have either some abnormal host or another type of infection that we are dealing with. That is possibly the most.
Yes, of course. As just again a pointer here, as Dr. Mohite has also pointed out, if you see a paroxysmal activity with all four limbs involved, then make sure that there is loss of consciousness to call it seizure. Because to have all four limbs involved without loss of consciousness other than myoclonic jerks, nothing else would fit in.
She's mentioned with loss.
Just pointing it out.
Yeah. Okay.
Then, sir, child was admitted only. During 12th day of ward stay at night around 11 p.m., child had second episode of paroxysmal
No,
activity.
but one sec, sorry. So this first seizure was on 4th day of the illness.
Sir.
So what happened from 4th to 12th day? How was the child?
Yes, a child was admitted only, sir, at Birla Hospital. Some injectable was going on for that
Yeah,
kid.
no, what is the condition of the
Sir,
child?
he was conscious, oriented. He was taking feeds also. Mother was feeding him. Some sickness was there for that child was on not bedridden completely, but he was given the bed rest only. But
What happened to fever? What happened to headache and vomiting?
fever was persistent, sir. For 12 days, fever was there during ward stay.
And headache and vomiting also?
Yes, sir. Vomiting was he was not having vomiting, but fever and headache was there, sir.
And there was no focal deficit till
No,
that
sir.
time?
During 12th day of the ward stay at night around 11 p.m., child had second episode of the paroxysmal activity, started off as a right focal side with loss of consciousness, lasted for 1 to 2 minutes. Then child was shifted to intensive care unit, injectable given, conversion aborted.
Fine. So now comes the inability to speak. So what do you make out of that? So on the 12th day of a intracranial infection or illness, there is a sudden inability to speak. So what do you make out of that? How will you pathophysiologically correlate it?
Content of the consciousness was gone.
Sorry?
Content of the consciousness.
You feel that the child dropped in consciousness?
Yes, sir. After this incident, child was unconscious only, like as per mother, bedridden, not speaking anything, and does not recognize mother at all.
No. After the seizure or after this inability?
After this second seizure, sir. Child woke up on his own by with spontaneous eye opening was there, but mother noticed child was not recognizing anybody, not talking that much the way he was used to speak before. And he was bedridden only with weakness.
Okay. What I understood was that child was not able to speak and quickly progressed into unconsciousness.
Yes.
Okay.
But eyes were open.
Eyes were open, sir.
So I think what she is describing is that after the second seizure, once the loss of consciousness that was associated with the seizure was over, the child could only open his eyes but was not responding to surroundings, right? So
Yes, sir.
was not aware, etc.
Not aware at all.
Okay. And was also seemed to be paralyzed all over.
Yes, sir.
Okay.
But what Dr. Rajesh asked, anyone can answer. What if there was only inability to speak in a child who had not lost consciousness after sufficient time of paroxysmal event. She had paroxysmal event and the child was sleeping, woke up in the morning, but was unable to speak. The rest of the things were normal. If that happened, that did not happen here. If that happened, what would you think?
It could be due to some infarction, sir, which result into insult to the MCA territory,
Very
to
good.
the superior division, resulting to Broca's
Excellent. In which hemisphere usually? The dominant hemisphere.
dominant hemisphere.
So, sir, how do we progress from here?
I think after the first seizure, it looks like that child remained conscious for some time.
First is sir, conscious
Isn't it?
only. After
So what does that mean really? We said that there was headache, then vomiting came on day 3. So looks like something that should have happened, a fever, headache, vomiting coming up over 2-3 days. That has happened. Then one episode of seizure. Are you sure it was not focal and it was general?
sir,
It's
it
not
started.
easy sometimes. A focal seizure which has now expanded to generalized is often missed as generalized seizure. The reason I'm asking is the second seizure was a focal seizure. So was the first also a focal seizure? And if it was a focal seizure, then there may not have been any other involvement of the rest of the brain, and the child improved completely after that seizure. Maybe a little drowsy after a seizure, a post-seizure, but thereafter regained conscious. It means that there was no encephalitis. There was one episode, isolated episode of a seizure. The seizure might mean, that's why I bring in a discussion of even a focal seizure. Focal seizure could be in a vascular origin or a localized, any other lesion, inflammatory. So we are open on that. But the child remained conscious thereafter.
Sir, after the first seizure?
Yes, I'm looking at the first seizure.
Yes.
And after first seizure, child remained conscious.
Yes.
Fever was continued,
Yes, sir.
but the vomiting headache was not much
there.
severe.
Vomiting as per sir, child was giving symptomatic treatment. So whether if he is having vomiting, it was being treated that time only. So he was hospitalized.
But
that
fever and headache continued.
Yes, sir, fever and headache.
And
was
on the 12th day, another seizure.
So probably, I would say that some treatment, which is obviously antibiotic, sometimes even steroids, has made a difference in terms of temporary difference in terms of no loss of consciousness or no worsening, fever continued. And so till then, if we had seen a child at that time, we would have said there must have been a focal lesion more than a general encephalon involvement. In a child who started with apparently symptomatology of raised ICT with fever, so one would have started looking at, could this be a small abscess somewhere developing if we are looking at a bacterial meningitis? Or are we looking at a vasculitis coming up because of a focal lesion? Okay. Because child has remained well in between for a time. Now the child comes with another seizure, and at this time there is a loss of sensorium, paucity of movements of all 4 limbs, inability to speak, etc. Which means now a large part of the encephalon is involved at this point of time. But the first time it was not. Okay. Now that makes me feel that, is it really an infection only, or is it something else happening? An infection should not have in between a fully conscious child who threw up a seizure, and then after some time he becomes suddenly bad. So some thoughts start coming whether it was infection induced some immune changes, or whether it was never an infective illness at all to begin with. So we start thinking at that time on that, because now it looks like that and large part of encephalon is involved in this child, right?
Go on. So there's nothing else after this, right? So what's your provisional diagnosis?
Sir, 9-year-old male child, second birth by order, born of
Speak in the mic.
9-year-old male child, second birth by order, born of non-consanguineous marriage, Muslim by religion, with history of headache, fever, vomiting with 2 paroxysmal activity, altered sensorium with signs of meningeal irritations. That time was present, which was catastrophic, acute in onset, progressive in nature, with dystonic type of involuntary movement disorder, with neuroregression, previously developmentally normal kid, with loss of speech in with a progressive encephalopathy involving cortex with extrapyramidal movement with no cranial nerve involvement, probably suggestive of meningoencephalitis secondary to. So for now, I have this differentials.
No, but out of all these big list,
TB.
what is your 1, 2 and 3, something like that?
First, sir, TB meningitis, because the way child has progressed, stages are there, sir, for TB meningitis. Second is pyogenic meningitis could be there, fever is there, autoimmune encephalitis, or immunocompromised like HIV, HSV encephalitis, and Adam.
Anybody would like to sort of argue for or against any of these differentials? Which of them is more likely? What do you think?
When you give a probable diagnosis, you don't give all causes of probability, just 2 or 3. Okay, here you have mentioned almost every possible things. That should not be there. So let's look at common ones first, 2, 3, and debate what it is. Right? Who will debate on that?
So take TB meningoencephalitis. Do you think anything is, you are uncomfortable with anything fitting in, or everything is okay, or what do you think?
So TB meningitis, the way the progression of the disease was described, so it could have progressed to vasculitis, which has caused the infarct and the paucity. And initially the child had headache and fever, and then later on there could be some meningitis and causing encephalitis, and the seizures had started, and then later the vasculitis stage, so which could have.
So the point is that from the history, it was generalized, all 4 limbs involved at one go after that second seizure. That's the odd part. No? It's not the story of a vasculitis. Even if you have multiple vasculitis, they are probably dissociated in time and all that.
And again, as the age advances, the TB, neurological TB gets more localized to TB meningitis, and encephalon part is much less. Younger the child, encephalitis is the major event, meningitis, yes, no. Clinically, no. By CSF, yes. So, looks like less likely.
What about pyogenic meningitis? Anyone? So what is odd or what is different for pyogenic meningitis?
The way it progressed so fast, and such global involvement.
Yeah, so initially the progress, but in fact that break from day 4 to day 12 and then day 12 sudden deterioration is also unusual, right? Okay. So should we go on to examination?
Yeah, I still feel that because in between there was a reasonably normal period, okay, we are looking at something that is not just continued infection, but something beyond that.
Just one point here, do not use the word neuroregression for this child, okay? Because any acute insult leading to loss of milestones, we do not like to call it regression. Regression is a progressive or a regressive condition, okay? So one-time event or a short span event with loss of milestones, you don't know whether it is arrest, loss of milestones versus a neuroregression. You'll have to see over a period of time whether the child is having neuroregression.
General examination, sir. Child is averagely built sick. Child lying in the bed in supine position with upper limb flexed position at elbow, raised finger with eye open, right-sided fixed gaze with spontaneous eye opening. Conscious, not oriented to time, place, person, not interested in surrounding, not responding if called by name or any verbal stimuli. No obvious facial dysmorphism. This was
But is the child conscious?
Not aware, sir. Not conscious.
Not
That,
conscious. Then just go back to
yes,
the first slide.
yeah.
Previous slide. No, when he's not conscious, why are you saying not responding, not interested in surrounding? Look, unconscious child does not.
Sir, eyes are open.
So is the baby conscious or not?
So sir's question is that when eyes are open, how do you decide on consciousness?
Conscious in the form of content of the consciousness and depth of the consciousness, sir. If child is talking which is irrelevant, yet that is content of the consciousness is lost, sir. Depth as in child is in coma, stupor, or in that kind of condition, that depth is lost. So here it is depth is lost, sir. So it is not, that child is not conscious.
So normally, eyes should not be open in an unconscious child. Now, if the eyes are open, you want to know whether the child is following somebody or a menace, for example. Okay, some idea that the child responds. After all, you know AVPU, whether he responds to where is the pain, whatever. I think that would have told us clearly whether this child was not fully normal sensorium-wise or otherwise. And I think in pediatric practice, AVPU is a good idea to talk about. Okay, and that would be the best way to do that. Obviously, this child is not alert, so A is not there. Does he respond to voice? Probably not. Does he respond to pain? That is the next thing. So you have to pinch him and see whether he responds. He does. Then you say, yes, he is not unconscious. Okay, and you is, of course, he is not responding to pain also.
Okay, go on.
Yes, sir. No significant findings from head to toe examination except for eyes having right-sided fixed gaze and mildly, averagely built child, so -2, -3 standard deviation. CNS examinations. In this, sleep cycle was like preserved only. Cranial nerve examination.
So what does that right-sided fixed gaze suggest?
Sir, abducens, palsy in raised ICT, which false localization signs, sir.
But why fixed gaze?
Again, sir, there is no movement of eyeball, that is no extraocular movements. So it could be intranuclear ophthalmoplegia, which is due to the raised ICT, which is causing insult to the orbital apex and result into the palsy of all three, third, fourth, and fifth nerve. Because child didn't follow light also, sir, and he's not having spontaneous eye movement. He's just having right fixed gaze.
I'm not very convinced of that. I would have thought that a fixed gaze would almost mean something like a non-convulsive status, or I don't know. I'm not very convinced about all three extraocular muscles being paralyzed. Tushar?
Generally we use, I'm open to correction, we use gaze for any central problems and palsy for a localized nerve involvement resulting into a movement of a particular angle. So in an unconscious child to say fixed gaze palsy would be difficult.
Okay.
In trigeminal nerve, sensory, there is no sensation, like couldn't perform. Dropping of the food from mouth, so there is no no power in the jaw muscle, sir. Facial nerve was not involved. Vestibulocochlear not performed. Glossopharyngeal pulling of secretion, gag reflex was absent. These two not. This is for motor system, optic bulk of muscle, no obvious flattening, hollowing, bulging of the muscle, hypertrophy of the muscle seen, disuse atrophy seen bilaterally examined, symmetrical, tone of the muscle, hypertonia is there, sir, in all four limbs. Not being played.
I think you need to have that video in the same folder or something.
Okay, sir. Class 9 spasticity sensor giveaway response was there in all 4 limb. Power was not there, 0/5 in upper and lower limb. Superficial reflexes, corneal was present, abdominal no response, sir. Plantar reflex extensor there. Cremasteric was there. Deep tendon reflex brisk response was there with clonus positive, sir. Sensory system, sir, couldn't detect anything. Dermatom couldn't perform. Examination of ANS, no evidence of any excessive sweating or flushing of the skin, no evidence of pupillary immobility, no evidence of retention or incontinence of the bladder. Cerebellar, no findings, I couldn't perform. Sign of meningitis for now not present there when child brought to me. Other system not involvement, sir.
So, okay, so summarize.
Yeah, sir. 9-year-old child, sir, with subacute history of fever, vomiting, paroxysmal activity with an altered sensorium with subacute onset of weakness of all 4 limbs with for now no. In previously developmentally normal kid with loss of speech which on examine found to be have class 9 spasticity in all 4 limbs with intermittent jerky movement of hand with exaggerated deep tendon reflex. With absent abdominal reflex with loss of power in all 4 limbs with 3rd, 4th, 6th, 7th sensory was gone. 9th and 10th cranial palsy in averagely built child suggestive of neurodegenerative disorder with progressive encephalopathy with diffuse cortical involvement with human sign affecting basal ganglia probably gray plus white matter disorder secondary to infective meningoencephalitis, autoimmune encephalitis, neurocysticercosis complicated by CVDs.
So, as Tushar already said, we wouldn't say neurodegenerative disorder. So, it's a progressive encephalopathy, all right, with diffuse cortical involvement, with affection of basal ganglia. And now, why have you brought in neurocysticercosis?
Sir, since child was showing both gray matter and gray matter and white matter involvement. Neurocysticercosis will be involving both, sir.
True,
and progressive progress.
No, but why should a neurocystis? What is the commonest presentation of neurocysticercosis? Focal seizure. So why should it start with so much of raised ICP as this story started with? And then have a generalized enkephalon involvement. You know, that doesn't really fit in neurocysticercosis. So that is out. So your main differentials are infective meningoencephalitis versus autoimmune. Now there, as sir already pointed out, that because of that kind of a gap in between and then suddenly the child went down drastically, you might almost think of a immune mediated complication of that primary illness, whatever that was, right?
Yes, sir.
Yeah. You have any investigations to show?
No, sir.
Okay. Anything has been done, investigations for this?
CSF was done, sir, and MRI was done. CSF TLC count was 1300. No other significant, no culture was positive for CSF. MRI was suggestive of...
No, the...
sugar was low, sir. Sugar was low, protein high. I didn't put any reports over here. Because
no, doesn't matter. Sugar low, proteins high, 1300
yes.
cell
Cells.
count.
And I don't remember.
Okay. And what else?
MRI was suggestive of, sir, some temporal... MRI was suggestive of some temporal enhancement only. And vasculitis was there. So child was put on some aspirin, so 75 mg OD they were given, and corticosteroid was given.
But CSF suggests that the child has meningitis.
Yes, sir.
And with low sugar and increased protein and increased cells, this is actually a bacterial meningitis. Viral will not have altered sugar. So there is meningitis definitely in this child. Clinically also we are all along thinking of a intracranial infective pathology. So how come meningitis doesn't occur in the diagnosis?
I have put, sir, meningoencephalitis.
She said meningoencephalitis.
Hmm.
Viral, did she say that? No.
In the differential she said, now she's just telling what the investigation has shown, and the MRI shows a temporal enhancement.
Only.
Right.
Yes, sir.
Okay. Okay. So you are treating the child with steroids and?
Antiviral and antibiotics.
If you have a temporal enhancement and an encephalitis-like picture, it's a good idea to think of HSV. And cover with acyclovir till you get a HSV negative PCR on your CSF.
Sir, anything comments?
No, I think meningitis was definite, and therefore, as we said, this looks like a meningoencephalitis. Now, etiology is something baffling clinically. Okay, TB looks unlikely because typically TB neurological neuroimaging should show basal exudate, hydrocephalus, vasculitis. Okay, all that is not seen. So TB looks unlikely. If it's not TB, then it's certainly not a bacterial infection. It's unlikely a viral infection with so many changes of the CSF cells, low sugar. So it doesn't look like a viral infection also. So then the question is, are we looking at some unusual infection beyond these usual ones? And I think that I would not be able to kind of even consider clinically, but yes, there could be many other infections which would do something similar. And obviously this is less likely a fungal infection because this child looks to be immunologically competent, so we will get away from the fungus also. For example, I am not aware what would the amoebic neurological manifestation look like. There is an amoebic encephalitis, etc. Okay, then you go beyond that and you say that can brucella cause neurological manifestation? Yes. Okay, can leptospira cause neurological manifestation? Yes. So we will have to kind of think what it is. To me, the first illness looked some infection, and the second worsening looks a complication of that. Okay, so I think we will have to look for the help from the laboratory about the etiology. But if you are giving steroids, is the child improving now?
No, sir, no improvement.
Okay, because steroids might be yes, but steroids would be a double-edged weapon. We don't know the etiology, and I think we will have to look at some unusual organism which has done all this, and of which we cannot clinically go by at all. Your impression on some other infections, etc.?
No, I totally agree, because you would definitely think of herpes when you say temporal lobe enhancement. Slightly elder, I mean the elder age group, neurosyphilis is something that can come like that. And all the other things wherein you have localized, because you have focal abnormalities also, like fixed case and things like that. So you have to cover up with an acyclovir, or you have to go in and do a biopsy or something, because you need a etiological diagnosis. And now you have the PCR panel for all these things on a CSF, which needs to be done at the earliest to prevent morbidity. This child might survive, but
any questions or any other comments from anybody? Okay, so fine. Next time, whenever we meet, you tell us what is the progress of this child, how he has recovered, or what has happened after treatment.
Yes,
right?
definitely, yes.
Okay. So we'll stop here today. Next Thursday is 26th Jan. It's a public holiday, so we will not meet on that Thursday. So we will meet the Thursday after that, which I think is 2nd of February. Okay. Now, as we announced, the format would be preferably one long case followed by a short 20-minute presentation by one of the faculty. So I think Tushar will be starting with, so you're not there on that Thursday. So then Amdekar sir will take approach to immunodeficiency as a short presentation, followed by we'll discuss if there's anything in that is to be discussed for 10-15 minutes. So first half is the long case presentation and followed by this, right? That will be on 2nd of February.
And I think if you all have any suggestions of what topic, 20 minutes, just giving you an overview of how to, then you dilate on that. If you have any such suggestions that you may like, ambiguous genitalia, for example, a renal tubular function, for example, something that somebody can make it simplified so that it sticks on your mind. So give us suggestions and we will try to, we have a large faculty, okay? We have half a dozen people on the chat and half a dozen of us here. So we have 12 people. Not that all brains put together means so much more, yes, but we will try to do everything that, give us suggestions, pass it on to him, we'll try to do that, okay? All right?
And we once again thank all our online viewers and our faculty colleagues online. Today being the first day, we are still getting a little organized after a long time, but we will streamline the things a little more so that we'll see how those online inputs can be more integrated. So thank you very much everyone for joining in, and we meet again on 2nd of February.